All right, for this part of the talk, I'm going to review the training paradigm that underlies a lot of the gait interventions that we provide in the research studies. So back in 2010, Kuo and Dolian delineated 4 biomechanical demands of walking. And what they looked at were functional subcomponents of the task of walking that needed to occur in order to walk. So they weren't concerned with how the individuals completed any of these individual subcomponents, just that they were completed. So the 4 that they identified were propulsion, limb swing, stance, and lateral or frontal stability or balance. So back in 2014, Holler et al. Delineated what criteria they were going to use in their research studies to define successful walking. So for propulsion, there needed to be directional advancement, meaning you couldn't step in place, you had to be moving in some direction. You had to have a positive step length for limb swing advancement, and this needed to happen on both limbs. You needed to have limited limb or trunk collapse, so you weren't falling down, you weren't buckling excessively, and you couldn't fall over. Importantly, success was defined as continuous stepping, and failure being not one but multiple consecutive gait cycles that were not successful. And because there's an emphasis on making mistakes, they weren't specifically looking for success. They wanted to be somewhere between success and failure. And as I mentioned with the biomechanical demands or the subcomponents, they weren't focused on how the tasks were completed, just that these biomechanical constraints on walking were actually considered. So to guide each of these biomechanical subcomponents is this figure here. So what you see on the left is assistance in the blue. So early on, after an acute injury, or maybe if they're just really impaired in general, you as the therapist may need to provide a lot of physical assistance because they just can't move that leg at all. But the idea is that as soon as they get even a little bit better, as the therapist, you're backing off as quickly as you can, so you're only helping as needed, and then continuing to back off until you're not helping at all. Notice that the blue line doesn't come all the way down to the bottom before the red line, which is air augmentation, starts to ramp up. So even as they are still working on getting good at the particular task, they're starting to introduce errors or mistakes into that aspect of their walking. So you can think about this figure for each of these subcomponents. So I'm going to give an example. With this particular gentleman, he has a lot of issues with his walking. We're only focusing on limb advancement. And you can see here that George needs to do all of the work to advance his limb. So we're starting way over here on the left side of the curve. Early on, it's both an elastic band and George pulling his leg forward because he can't do it on his own. But as quickly as we can, we're going to try to back off. So you see that both George and the elastic bands are gone. There's still a lot of body weight support to help with giving space for that limb to clear. In this case, we're going to still be helping. So now the elastic bands are back, but we've dropped the body weight support. So still within the same biomechanical subcomponent, but different aspects of challenging that task. He clearly hasn't mastered walking over level ground, but that doesn't mean we're not going to wait until that happens to make it harder. So if you have a difficult time advancing your leg over level ground, going upstairs is going to be even more challenging. And now in this one, we're back to level ground, but there's a 10-pound ankle weight on that leg. So really challenging that aspect of their walking. Different individual. In this case, we're going to look at both their stance stability, so them not buckling, as well as propulsion, or their ability to step in a particular direction. So really slow. So early on, this is really challenging propulsion. So it might not look fast, but for them, it's relatively fast. In this case, George is actually dragging him down the hall. So he's providing assistance for propulsion. So really trying to help get him to go faster or propel faster. Stairs is really going to challenge stance stability. So if you have a difficult time not collapsing during overground walking, the biomechanical demands of stairs are going to be much greater, so that's really going to work on that and trying to go faster to work on propulsion. The rotating stairs are just going to be another way to get lots of practice in. So nothing specifically different or magical about the rotating stairs, just another way to do this. And then as they get better, you're going to start to try to ramp up the airs. So the treadmill is faster, but the same ideas are still there, where you're trying to have them make mistakes. You're trying to have them do the task a little bit faster or a little bit more difficult than they would be entirely successful at. All right, same individual, different deficits. You can see right there that if the therapist didn't chime in to help with steering the walker, that it would tip over. So really focusing on balance. So clearly hasn't mastered walking with the walker, but not waiting until they do before we start having them make mistakes, decreasing the lateral stability support that they have, and continuing to do so. So not good at walking over level ground, still going to challenge them even more. And eventually the balance beam became a little bit too easy, so had to get creative and rolled up the mat. You do see that they have their cane here, so they have a little bit extra support with that, but still really trying to challenge them in different contexts. Here, working on some of those other things that we just talked about, but you see that he's not holding on to the rail. So you're able to potentially challenge multiple subcomponents at one particular time, which may be important given that most of the time our patients have issues with many or all of these subcomponents. All right, different individual, clearly walking faster at the start, so they don't need assistance. So we're going to go straight into augmenting airs with propulsion. So a lot of facilities have light gaits. This isn't a typical use for a light gait, but there's no reason that you couldn't use that in that capacity. Walking uphill is going to be another great way to augment their airs because it's more work propulsively to go uphill than it is to go over level ground. This is their first attempt at running on a treadmill. And then a couple weeks later, this was at the end of their training. So the important thing to take away from this is that you have this figure that kind of guides where you might be, and we might end up spending more time on the left side where early on we need to assist, but as soon as we can, we're backing off and really trying to ramp up the mistakes they make and continuing to try to challenge them within these subcomponents. So to put this paradigm to really try to delineate what might be specifically contributing to its benefit in individuals post-stroke, there were previous studies including some case series and then a randomized trial comparing this intervention to conventional therapy, where this was found to be much better in terms of the walking outcomes that were achieved without sacrificing any of the non-walking outcomes like the balance and the transfers. So with this intervention, you're throwing a lot of things at these people, keeping in mind the principles of neuroplasticity, specifically throwing intensity, variability, and lots of practice at them. So the purpose of this study was to look at the relative contributions of stepping intensity and variability on the walking outcomes in these individuals with chronic stroke. We hypothesized that high intensity stepping, specifically in variable context, so I'll get into what that means in a second, would be better than similarly high intensity stepping but only in the forward direction, or low intensity stepping in variable context. So really trying to tease out the contributions of intensity and variability to these walking outcomes. So to answer this question, we recruited individuals that were at least 6 months following stroke and had a unilateral hemiparesis. They had to have walking deficits, but they also had to have some walking function. They were allowed to use their customary assistive device and an AFO if they needed to. We excluded individuals that had other neurologic or orthopedic injuries that might affect their walking. We excluded individuals that had cerebellar ataxia because we know the cerebellum is important in motor learning and we didn't want that to confound the results of the study. And we wanted to make sure that if they were getting better in their walking, it was because of the therapy they were provided in the research study and not therapy they were doing elsewhere. Eligible individuals were randomly assigned to one of 3 groups, and they completed up to 30 one-hour-long training sessions in up to 9 weeks. So the first group here is the high-intensity variable training group. So this was the experimental group where we combined high-intensity stepping and variable contexts. These individuals targeted at least 70% of their age-predicted heart rate reserve and ratings of perceived exertion of at least 15 on the Borg RPE scale, or hard. So during their sessions, they would do up to 10 minutes of forward treadmill training. We're really trying to challenge propulsion. They would do 10 minutes of variable treadmill training where they would do up to 2 to 3 tasks, specifically targeting those biomechanical subcomponents we talked about. You can see here working on making mistakes and learning from them, so some level of success, but not always being successful. They did up to 10 minutes of stairs, also in a variable context, still targeting those biomechanical subcomponents. And then finally did 10 minutes of overground training, again, specifically getting at what might be functionally limiting them in the community, as well as those biomechanical subcomponents specific to their deficits. All right, next group is the high intensity forward group. The intensity was still the same as the previous group, but these individuals only practice forward walking. So what that means is they spent up to 20 minutes on the treadmill, only walking in the forward direction. So we're only really challenging speed to make that harder. And they also did up to 20 minutes of overground training. Again, really just trying to use speed to increase the cardiovascular intensity that we were looking for. Finally, we have the low intensity variable group. This group differed from the previous two in that the target intensity was much lower. We tried to keep it at 40% or less of the age predicted heart rate reserve and ratings of perceived exertion of somewhat hard or less. Otherwise, the interventions were still in line with the first group. So what that means is they're still spending 10 minutes working on forward treadmill training, 10 minutes doing variable tasks where we're targeting those biomechanical subcomponents. We're still trying to get them to make mistakes. We're still trying to have them do difficult tasks. The only thing that's different with this group is that the cardiovascular intensity of the task is much lower. So outcomes were assessed before, after, and at a 3-month follow-up, with primary outcomes of self-selected and fast walking speed, and the 6-minute walk test with the directions to cover as much ground as possible. Secondary outcomes were included spatiotemporal outcomes, so looking at recovery of normal walking patterns, as well as several clinical outcome measures. Because we were specifically comparing high and low intensity, we also wanted to track the incidence of adverse events. So they were then stratified by whether they were serious, so dying being obviously a bad thing, falls with injury outside of therapy, and any kind of hospitalization, versus minor, which is essentially anything else that might come up that was unexpected. We assessed 152 individuals for this study. 97 were ultimately randomized, with 90 completing at least 10 sessions. All but 10 of those individuals participated in the follow-up. In terms of the demographic and training attributes of our participants, there were no differences between the three groups in the number of sessions they completed. There was a difference in the number of minutes that they spent practicing the task of walking during each session. So if you remember, the goal was to get to 40. In this study, we found that the low intensity variable group was able to get the most practice, and that was significantly greater than either of the high intensity groups. As intended, the high intensity groups had significantly greater average heart rate reserves during their training sessions, as well as ratings of perceived exertion when compared with that low intensity group. In terms of the amount of practice walking that was actually provided, for both the steps per session, which is going to be the total amount of practice, as well as the steps per minute, which is going to be the rate of stepping during walking, the high intensity forward group was significantly greater than the high intensity variable group, which in turn was significantly greater than the low intensity variable group. For our primary outcomes, there were no differences at baseline between any of the three groups. Here you can see the changes in self-selected walking speed. The changes in fast walking speed had a very similar relationship and aren't displayed here. But what you see is that the two high intensity groups have large gains in their self-selected walking speed at both post and then maintained at follow-up, with much smaller gains in the low intensity variable group. So the differences are statistically significant between the two high intensity groups and the low intensity group, as well as you see the dashed gray line here, which is the clinically important difference for this measure in chronic stroke. So it was also clinically significantly different between the groups. When we look at the 6-minute walk test, we see very similar things, where you have large gains in the two high intensity groups that were maintained at follow-up, and much smaller gains in the low intensity group. And again, these straddle the clinically important difference for this measure. For the spatiotemporal outcomes, we're looking at the recovery of normal walking patterns. For paretic single limb stance time, we see that high intensity variable and high intensity forward significantly improved this measure, meaning that the individuals walked more normally in this aspect of their walking when compared with the low intensity variable group following training. When we look at step length asymmetry, we see that there were no differences between any of the three groups. For the other clinical outcomes, the functional gait assessment had a p-value for 0.06 for the on-protocol analysis. That means for only the individuals that completed at least 10 sessions. If you take it back a step and look at the intention to treat, meaning that you look at anyone that was randomized to any of the three groups, regardless of how many sessions they completed, the p-value becomes 0.03, where you have a significantly greater improvement in the FGA in the high intensity variable group when compared with the high intensity forward group at post-testing. When you look at the ABC scale, there were no differences across the three groups overall. However, you see that there's a significant group by severity by time interaction effect. And what this means is when you add the factor of their baseline gait deficits, you see that specifically individuals that have initial gait speeds of 0.5 meters per second or less and received high intensity variable training had significantly greater gains in their ABC scale than any of the other individuals, regardless of what intervention they were provided. Okay, so when we look at the idea of a dose-response relationship, so similar to previous studies, we're interested in looking at whether the amount of walking practice provided is related to the amount of change in walking outcomes. In this case, it's steps per minute that's shown. It was the same results with steps per session or training intensity. But you see a statistically significant positive relationship for both the changes in walking speed and the changes in 6-minute walk test. So what this means is that the more practice walking you had during training, the more gains that you got in your walking outcomes. Okay, for adverse events, importantly, there were no serious adverse events in any group. There were minor adverse events that were observed. These weren't different between groups. The minor adverse events primarily consisted of musculoskeletal pain and falls without injury outside of therapy. All right, so what do we take from all of this? The contributions of intensity seem to be clear. We saw statistically and clinically significant differences between the two high and low intensity groups. The increased heart rates during the high intensity trainings are likely driven by elevated neuromuscular demands, such as the observed increase in steps per session and stepping rate. And these metrics were in turn associated with the changes in locomotor outcomes. The contributions of task variability and difficulty are less clear. We saw no differences in the FGA or 5-time sit to stand with the on-protocol analysis. Although I did mention it was significant with the intention to treat, it's still unclear whether that about 1.6 point change is clinically meaningful, but you know, we're talking about maybe having some contribution there. And we did have that subgroup of the more impaired individuals showing greater gains in their ABC. So less clear, but maybe something there for the contribution of the the task variability and difficulty part. We saw spatiotemporal gains in the two high-intensity groups in one of the measures, despite not focusing on kinematics during that group. And we saw that there weren't any differences in the other measure. So even though we didn't focus on it, they didn't, in one measure they got better, and in the other measure they stayed the same as the other group. So importantly, the idea being that you don't have to focus on normalizing kinematics to either get better at your kinematics, or it's not going to make you worse if you don't focus on it. And importantly, there were no group differences in adverse events. So you have these much greater gains in walking outcomes without any increased risk. All right, so we have that study that tells us that intensity in particular is something that's really important to keep in mind with our interventions. So the point of this next study I'm going to talk about is attempting to delineate whether it matters what you do when you work hard, or do you really just need to really work hard. So in American Inpatient Rehabilitation, this study happens to be in spinal cord injury. Stepping practice is not specifically prioritized. Even in ambulatory individuals with incomplete spinal cord injury, they get about 100 steps per session. And we know from the previous study as well as other studies that if you prioritize walking in these individuals, you can get easily upwards of 2,500 steps per session. Interestingly, they saw that these individuals had about twice as many non-walking leg movements during their sessions. So these primarily came from transfers, balance tasks, lower extremity strengthening tasks. But the fact that they're getting twice as many means that that type of activity is being prioritized in the therapy sessions. More recent work on these impairment-based interventions has suggested that when you really push it for these interventions, that they do result in some gains in walking outcomes. So that leaves us with the question of, do we really need to get lots of stepping practice working hard? Or if we work really hard doing these impairment-based things, is that just as good or even better for walking outcomes? So the purpose of this study was to investigate the role of specificity of training on locomotor outcomes in incomplete spinal cord injury. We hypothesized that high-intensity stepping practice would be better for walking outcomes than high-intensity non-stepping practice. To answer this question, we recruited individuals that were at least 1 year following their incomplete spinal cord injury. They had to be at the level of T10 or above. And similar to the last study, they had to have some walking deficits, but also some level of walking function. We excluded individuals that had other neurologic or orthopedic injuries that might limit their walking, and they also couldn't be participating in other physical therapy at the same time. For this study, we used a randomized crossover design. So what that means is individuals came in, they did their baseline testing. They were randomized to do either the walking training or the non-walking training over 6 weeks. Up to 20 sessions is what they were able to do. After we tested them, they took at least a month off, and then they came back and they did the opposite intervention. So randomized into what you did first, but everyone ends up doing both of the interventions. For the task-specific training, it's exactly the same as the high-intensity variable group from the last study. So targeting cardiovascular intensities of at least 70% age-predicted heart rate reserve, ratings of perceived exertion of at least hard, targeting those biomechanical subcomponents during their walking, making mistakes, making it difficult, whatever we can do to make it specifically relevant to them. You can see kind of the spasticity kick in his legs, not something we're concerned about as we go. All right, so you're familiar with that at this point. The other group was the non-specific group, or the non-stepping practice. So similar cardiovascular intensities were targeted. However, in this group, we're going to spend time doing lower extremity strengthening. We're going to spend time doing balance. You can see weighted vests, ankle weights, lots of things to try to get the cardiovascular intensity up. Aerobic training, usually on like a recumbent step or like a new step or a bike like this. And then transfer training. So that could be bed mobility, that could be sit to stand, that could be floor transfers. Again, you see the vest, the Bosu ball, other things we can do to try to increase the cardiovascular intensity and difficulty of the task. The outcomes for this included the fastest walking speed over ground, as well as the peak treadmill speed. Secondary outcomes included the overground self-selected walking speed, 6-minute walk test with covering as much ground as you can, the Berg balance scale, 5 times sit to stand, ABC, and then the recumbent stepping test, which is what you see here. So what you're doing is similar to the peak treadmill speed, where we're trying to get them to maintain a particular cadence on this, and then every 2 minutes the resistance is increased until they can't maintain that cadence. And the last speed that they're able to successfully do, we calculate a wattage based on the cadence and resistance to figure out their performance on this test. So we had 16 individuals that participated in this study. We identified no group differences in any of the demographics. For the group that they did first, it's not nearly as big of a deal for a crossover study because everyone ends up serving as their own control, but helpful in terms of us being able to analyze the results knowing this information. No differences in the number of sessions that each group completed. There were differences in the number of steps during each training session, which was intended, because one group practiced walking and one group did not. Cardiovascular intensities of the sessions were different. I mentioned that we tried really hard to be creative in getting the heart rates up in the non-specific group, but it was really difficult with tasks like balance and strengthening to get those heart rates up. However, the RPEs were similar, so the tasks were perceived as really difficult, even though the heart rates weren't as high. When we look at the outcomes for this, so when you see you have lines on the left and lines on the right, that's looking at which intervention they did first. So for the non-specific group, regardless of whether they did the non-specific training first or second, they had relatively small changes in their fast overground walking speed. However, conversely with the task-specific group, regardless of whether they did it first or second, they had relatively large gains in walking. What we're most interested in here is the time by group interaction, meaning that from before to after the intervention, doesn't matter what group you're in. In this case, it does, where you get significantly greater gains in overground walking speed with participation in task-specific training. When we look at peak treadmill speed, we see very similarly next to no change in the non-specific group, large changes in the task-specific group, and significantly different between groups. For the other outcomes, 6-minute walk test, significantly different with greater changes in the task-specific group. ABC also significantly different, favoring the task-specific group. And then if you remember, we did that recumbent stepping test. That was significantly different between groups, this time favoring the non-specific group, which if you remember, practiced that task as part of their training. Similar to the last study, looking at potential dose-response relationships. In this case, it's changes in steps per session. So keeping in mind that everyone did both interventions. So for this case, across the bottom, we're comparing the number of steps they got in their typical task-specific training, where they did a lot of walking, to the number of steps they got in the non-specific training. And then on the y-axis or vertical axis, looking at how that is associated potentially with their changes in walking outcomes. And at this point, you might be able to guess what the story is, where the more practice walking you get, the more gains you get at walking. So this was true for both the fast overground walking speed and the 6-minute walk test and was statistically significant. So take homes from this study, we saw greater gains in walking outcomes when you practice walking as opposed to practicing something else. We saw limited walking gains when you do those impairment-based strategies, but you got better at what you practiced, which was the new step. So important to keep that in mind, that it's not just working hard, it's what you do. So the take home from my part of the talk, when you walk, you really want to walk at a higher cardiovascular intensity because that's associated with greater walking gains. When you're going to work hard, it's really important to walk because if you walk, you get better at walking. If you work hard at something else, in this case, the new step, you get better at something else.